Wonderful. Good to see you all. Welcome to this exciting session. Thank you for joining us at the EPIC conference today. My name is Jessica Wong, an assistant professor in the Faculty of Health Sciences at Western University, and I will be chairing this second session of the EPIC conference on healthcare and health service delivery. I'll start off with land acknowledgement. And I'm coming here from Western University in London, Ontario. We acknowledge that Western University is located on the traditional territories of the Anishinaabeg, Haudenosaunee, Lenape, and Chinantan nations, on lands connected with the London Township and Samba Treaties of 1796 and the Dish with One Spoon Covenant Wampum. This land continues to be home to diverse Indigenous peoples, First Nations, Métis, and Inuit, whom we recognize as contemporary stewards of the land and vital contributors of our society. I would also welcome you to provide your own reflection and acknowledgement from where you are, and also feel free to share if you would like in the chat. Before we begin today's session, I'd like to note the EPIC conference sessions are taking place on Zoom from 12 to 1 p.m. Eastern Time, Tuesday to Friday this week and next week. We encourage you all to attend the sessions. Check out the AgeWell EPIC conference webpage to download the EPIC conference program, which includes details on each challenge area. For the format today, I will begin today's session with my short presentation on the healthcare and health service delivery challenge area. Then we will enjoy 2 research presentations with a 5-minute question and answer following each presenter, followed by a moving the dial presentation featuring a supported startup or program. And finally, we will close the session with a general Q&A. I am very excited to introduce today's EPIC conference presenters. I will have a more formal introduction with their bios later on in the session, but to highlight our presenters, we will first have James Hanratty present Developing and Validating a Discrete Event Simulation Tool for Nurse Workload and Patient Care Quality in Complex Continuing Care Settings. The second presentation will be from Marina Motzinek and Mary DeMayo, who will present on exploring ways to make the virtual emergency department more accessible to older adults. Finally, Justin Weiss will highlight how NovaSense is moving the dial by improving quality of life for Canada's older adults and caregivers. All of you are encouraged to use the Q&A box, so shown at the Zoom section, to ask questions, leave a comment on a question, and upvote questions that others have submitted, particularly if they resonate with you. We also welcome you to use the chat. This is an opportunity for you, our conference attendees, to contribute to an overall discussion that places the presentations in a larger discourse and addresses potential research as well as real-world impact. The session is being recorded and will be available for playback. Links to playback will be posted on the EPIC conference webpage in the AgeWell YouTube channel. Should you choose, you can enable closed captioning for Zoom on the Zoom toolbar. So, without further ado, let's begin with a short introduction and presentation to AgeWell and the challenge area of healthcare and health service delivery before going into our 3 presentations. So what I'll do is I will share my slides. For those of you who are new to AgeWell, to highlight this unique Canadian network, AgeWell has a vision. Canada's leadership in technology and aging benefits the world. The mission of AgeWell is to develop a community, a diverse community that accelerates the delivery of technology-based solutions that make a meaningful difference in the lives of Canadians. And this community includes researchers, older adults, caregivers, partners, and future leaders. You'll see here from the image that AgeWell is engaging with a wide range of groups, and these numbers keep growing. So to highlight a few, this includes researchers, highly qualified personnel, older adults and caregivers. There are partners, including international collaborations, as well as startups supported by AgeWell. We are faced with 8 challenge areas that AgeWell has prioritized, one of which is healthcare and health service delivery. Challenge areas represent important but complex problems that require innovative solutions, digital solutions at times, to then overcome these challenges and ultimately improve quality of life for older adults and their caregivers. Within the healthcare space, older adults and caregivers face challenges in accessing care when needed. This can look like challenges in going to appointments, navigating the complex healthcare system. And when it comes to technologies, even things like affordability or accessibility can be challenging, and things that we need to consider to ultimately improve quality of care. To provide some context and to highlight an area that my research team is looking at, I will give a research example of how we are trying to tackle this challenge area within the healthcare and health service delivery space. If you are interested in learning more, feel free to reach out to me. To provide some context, older adults are experiencing complex health problems and often require healthcare services to improve their functioning and quality of life. However, many older adults are not able to access the care when needed, and these tend to be system-level issues. Things like costs, wait times, transportation challenges, and so forth. And these can lead to what we call unmet healthcare needs. These are needs for healthcare that are then unmet. And when left unresolved, it could lead to worsening quality of life. In fact, every year, about 1 in 9 older Canadians experience unmet healthcare needs, and this is likely higher for those with complex health problems. One of the key issues that we've identified is that we do not have an accurate method to predict who will develop unmet healthcare needs among older Canadians. Allowing us to predict this is actually then allowing us to do forecasting and planning for the future, such as how many older adults will experience unmet healthcare needs, and ultimately, what are ways in which we can prevent them. So the goal of our project to address this critical area is to develop and validate a digital tool. The tool is called Unmet Needs Population Risk Tool, or UPORT for short, to predict unmet healthcare needs in older Canadians. This is an ongoing project, but I'll highlight a few key approaches that we are using to develop the UPORT digital tool. One is that we are co-designing with an advisory group of knowledge users that includes people with lived experience and caregivers to ensure that the research is meaningful and impactful to communities. We're using advanced methods to develop and validate this prediction model, and that is using data from the Canadian Longitudinal Study on Aging. And once validated, the UPORT tool will be able to guide population risk assessment and ultimately allow us to identify strategies to optimize delivery of care and meet the needs of older Canadians. And now we will look into 3 key presentations that further show us innovation in tackling these complex problems within the healthcare space. And so with this, I will introduce our first presenter. And I'm very excited to introduce James Hanratty. James is a PhD candidate from the Department of Mechanical and Industrial Engineering at Toronto Metropolitan University. His research focuses on applying engineering technologies such as discrete event simulation and biomechanical simulation to study nurse workload and patient care quality in clinical settings. James is a licensed engineer and paralegal in the province of Ontario. He completed his bachelor's in industrial engineering at the University of Toronto, Master's in Mechanical Engineering at Toronto Metropolitan University, and MBA at the University of Toronto's Rotman School of Management. And James will be speaking to us about this discrete event simulation tool for nurse workload and patient care quality in complex continuing care settings. So I'll invite James to share screen, and over to you.
Thank you so much, Jessica. I'm just going to share my slides. Okay, great. So thank you everyone for having me. Unfortunately, my co-presenters, Veroneike and Gabby, weren't able to make it today. Unfortunately, there's an outbreak on their complex care unit, so they send their regrets, but I'll be presenting on their behalf as well. And I'll be sharing our collaborative research work where we've developed and validated a discrete event simulation decision support tool to help with some of the workload and patient care quality decisions on their complex care unit at UHN. And so the premise behind our work is that, for many decades, nurse workload levels have been very high and unsustainable. And this has led to negative outcomes across the board for nurses, patients, as well as healthcare systems. We have the Better Work, Better Care framework here, which actually nicely summarizes that, on a daily basis, there are design and management decisions that are made that either directly or indirectly impact the workload of care delivery systems. And that could be at the unit level, that could be at the floor level, the hospital level, the network level. And what we've seen from the literature over these past decades is that there have been negative outcomes due to due to the nurse workload problem, where nurses, for example, have struggled with burnout, injury, turnover. Patients have struggled with lapses in care quality, and then healthcare systems have faced greater costs as a result of these workload issues. And so what our team is doing is essentially using computer simulation as a new approach to studying this kind of topic. Also, something to note is that workload assessments are limited in limited use currently in healthcare systems. And so we hope that with our decision support tools that we develop, we can better measure workload so that way it can be better managed. So this here is just an overview of our tool architecture. So one of the key takeaways here is that on the right, we can see we have a lot of outputs. Primarily, we're focusing on physical workload as well as mental workload and care quality. And in order to get a lot of these outputs, we have to have a lot of data inputs. And so we do extensive data collection with our study partner. So some examples include for institutional data, we collect daily nurse patient assignments. We also access some de-identified diagnostic data. So some examples include pressure injury prevalence, treatment outcomes, etc. For job shadowing, we follow nurses and PSWs throughout the duration of their shift, where we get a better sense of the care logic and their movement patterns. We also conduct time and motion studies where it's very similar to job shadowing, except now we're actually timing the care tasks as they're being delivered. And then we also conduct interviews and focus groups to get a better understanding of how nurses and PSWs prioritize the care that they deliver. And then for validation purposes, we also collect a lot of data. We take in unit measurements. We also conduct step counter studies, and we administer a miscare survey, which I'll discuss a bit later. So this here are just some examples of some of the results that we can get from our tool. Now this first one here, this figure 3, this shows how, so we've collected time data from time and motion studies, and we use the time data for each of the care tasks to map to a statistical distribution. And these statistical distributions are essentially the bread and butter behind our tool. So for this particular example of pressure injury care, we have two types of distributions. We have our duration distribution, which governs how long the task would take at any given occurrence. And then we have the interarrival time distribution, which governs the frequency and arrival of these care tasks for a given shift. And here in figure 4, you can see that this is just a screenshot from our tool, but essentially we have a virtual rendition of this complex care unit. So essentially it's a digital twin. And so whenever the simulation runs, you can see the virtual nurses moving about this virtual unit completing their care tasks. And here in figure 5, we have an example of one of the many validation tests that we conduct to ensure that the tool is accurately representing the unit or the actual care that's being provided on the unit. So here, this particular test is the walking distance test, where we have conducted a step counter study where we've had participants wear a Fitbit, and then we use that to calculate their actual walking distance. And then we map their movement patterns in the tool, and then the tool outputs the model's version of the walking distance, and then we compare the two. And from our comparison, we can see from an interclass correlation of 0.95, which really shows a high similarity between what's actually happening and what's being modeled in our tool. This here is another example of one of the outputs from our model. This is from the PSW side of our study, where we've looked at missed care as we've increased the patient load, and we've also looked at care waiting time, which is in red. And so currently on this complex care unit, the PSW per patient assignment is six patients per PSW. And what we can see already is that that is right on the cusp or at the edge of the cliff where, if we increase the patient load, we actually see a drastic increase in care waiting time as well as missed care in the tool. So this is an example of how this kind of tool can inform, management as to, whether their staffing level is sufficient or, will there be impacts on workload and care quality. This here is another example from one of our previous studies. This one was done on a medical surgical unit. Here we've also looked at missed care. We've also looked at patient load, but we can also look at other things too, such as patient acuity or patient dependency. So in this particular case, we look at patient acuity, and we can see that as patient acuity increases, there's also an increase in missed care, and we can also see that the greater time is being apportioned to patients with greater acuity levels. So again, coming back to the impact of this type of tool, we can essentially impact test and use this tool as a test bed to see what prospective design and management policies, what effect they will have at the unit level, at the hospital level, et cetera, depending on whatever your scope of modeling is. For us, it was it was at the unit level. And we can essentially impact test prior to implementation. So, some other experiments that we have lined up include looking at the costs of pressure injury prevention versus treatment. We can look at the workload and care quality effects of an 8-hour versus a 12-hour day shift. We can turn the dial on staffing levels and see, what the impacts are there as well. And a question we have for the audience, which we can probably discuss in the Q&A, is what would you like to know? And we can see if we can try to model that with our decision support tool. So now I'm going to turn to the UHN perspective. And so this was prepared on behalf of Veroneike and Gabby from the unit side. So for this complex care unit over the past year, they faced changes in terms of the patient population. And one of the things to note for complex care is that the patient population is very dependent on their nurses and PSWs with support for activities of daily living. So there's a high burden placed on their care providers. And on top of that, this is a very vulnerable patient population. And so for the past year, there have been some changes to this population. There's been some changes in terms of the model of care. And so the nurses and PSWs have found this study as a great way to sort of objectively measure the work that they're doing. And they see this as a benefit to help improve their care delivery as well as supporting their safety. And they're also very eager in participation. I know this firsthand. And one of the things that they like about our study is that as sort of as non-clinical researchers, we don't have a nursing background, so we can provide sort of fresh perspective to the work that they're providing, and help in some ways to support unbiased data collection. Particularly in the focus groups and interviews, the nurses and PSWs felt that it was a great platform for their voices to be heard, in order for them to help depict the challenges that they face on a daily basis. And so they look forward to the completion of our study, and they look forward to some more findings. And with that, I'd just like to close out. We have a QR code here, which provides you a link to some of our other published works. We also host the Better Work, Better Care Coalition, which is a professional network of like-minded individuals that believe if you improve the working conditions of nurses and PSWs, you'll get better care as a result. So we have our link there to our LinkedIn group. And of course, we'd like to acknowledge our study partner, the South 5 at UHN, as well as all the participants, the staff, the family members of the patients. They've all been very supportive of our work. And of course, we'd like to acknowledge our funding partners, CIHR, NSERC, AgeWell, and Pearly Health. And so with that, more than happy to answer any questions. Thank you.
Thank you very much, James, for an interesting presentation and innovative work. So I welcome others attending to share your comments or questions in the chat or Q&A, and I can moderate the session. So to start off, we have a question from Vicky Young. Vicky says, very interesting. Wondering how you know care is missed, or how do you measure missed care? Do staff self-identify?
That's a very good question. So first of all, just to distinguish, miscare in our tool is defined as, so currently we're modeling an 8-hour day shift on this complex care unit. And so what happens is that if there's any care tasks that extend beyond that 8-hour duration in our tool, that's classified as missed care. Now, in reality, that might not actually happen. In reality, what tends to happen, especially from what we've learned from our focus groups and interviews, is that care isn't necessarily missed, but is actually rushed. And so really our missed care in our tool is more so sort of an indicator as to, the likelihood that care might be rushed, and might be substandard in the actual unit. Now, in terms of validation, we do administer the missed care survey, which the nurses will provide, as well as PSWs will provide their sort of perspective as to how often they feel care is being rushed or missed. And then we can use that as a way to sort of validate the missed care that comes out of our tool. And so what we've seen so far is that there's a very close match between both the miscarriage survey and our tool. So we can say that it somewhat accurately reflects what is happening on the unit in terms of whether care is being rushed or is being provided at substandard level.
Great, thank you. And I have a question as well. So you had described in your methods that you had used a combination of patient data, care logic, interviews, focus groups. I guess, were there any challenges that you faced in having these different forms of data, and how did you overcome it?
Yeah, that's a very good question. One of the great things about at least the software that we're using, it's FlexSim healthcare simulation software. One of the great things about this kind of software is that it's tailored directly to healthcare. So that way, it's a lot easier for us to develop the tool itself, the virtual rendition, all the movement patterns, etc. In some of the past modeling work that our team has done, we've used other types of simulation software, which is more generic. And so it's been much harder for us to sort of capture accurately what's happening on a particular unit. Other challenges include, just the amount of data that we have to process and pre-process in order to enter into the tool. And, in terms of data collection, for example, like job shadowing and time motion study, there's some instances where the nurses and PSWs are skipping their breaks just to complete care. And so, we also have to do that as well, skip our breaks as well, just to make sure that we're accurately capturing how their time is being spent. So it really is very eye-opening, especially as a non-clinical background. It's very eye-opening for myself to see, what the nurses and PSWs go through on a daily basis to provide the level of care that they want to, high quality of care.
Great, thanks. And so we have one more question, and maybe I'll ask James that this will be maybe a shorter answer, and you can provide a longer one if needed in the comments. Tarai is asking, can this tool be applied to dynamic teams like a clinical lab that runs both in patient phlebotomy and run outpatient phlebotomy clinic provided by laboratory assistants?
Yes, so this kind of tool, the scope can be definitely changed. So right now we're just focusing at the unit level, but if we want to sort of look at sort of inter-unit relations, as well as inter-staff relations, where for example a team-based care model where it's not just nurses, but you also have PSWs and other roles involved, that can also be modeled with our tool.
Great, thank you so much, James.
Thank you.
Excellent. So we'll move on to the next presentation, and I'll invite Marina Motsanak and Mary DeMaio. And to provide bios and formal introductions, Dr. Marina Motsanak is a research associate at Sunnybrook Research Institute. She is a behavioral scientist and an applied health services researcher who focuses on mixed methods evaluations of innovative models of care. Her work is dedicated to optimizing the implementation of healthcare interventions with an emphasis on improving the quality of care for older adults in areas such as healthcare transitions, rehabilitation, and emergency services. Mary DeMaio is a registered nurse with over 30 years of experience working in the emergency department in a variety of nursing roles. For the past 20 years, Mary has been working as a nurse practitioner, primarily in the emergency department. She has been working in the Sunnybrook Virtual Emergency since it introduced nurse practitioner-led care 20 months ago. And they'll be speaking on making virtual emergency departments more accessible to older adults. So over to you, Marina and Mary, and you can share your screen as well.
Thank you for this kind introduction. We're happy to be here and are grateful for the opportunity to share some of our research today. This study is part of ongoing evaluation to inform strategies for compassionate virtual urgent care for equity-seeking groups. The principal investigators on this project are Dr. Sander Hitzig, who is a senior scientist and the research director of St. John's Rehab Research Program at the Sunnybrook Research Institute, and Dr. Justin Hall, who is a scientist, chief of emergency medicine, emergency staff physician, and the virtual ED director at Sunnybrook. I will turn to Mary to do some introduction.
Thank you. Good afternoon, everyone. To start, we will identify the current state of Ontario's emergency departments. Essentially, they are in a state of crisis. Unfortunately, this has been the state of affairs for quite a while and has only worsened since the pandemic. For this reason, new strategies had to be considered. Interestingly, prior to the pandemic, Ontario Health was looking at virtual care as a means of addressing emergency department overcrowding and hallway medicine. But when the pandemic happened, virtual emergency care was quickly implemented in 14 emergency departments across Ontario. It was necessary as people were afraid of going to the emergency, let alone going out in public. In the emergency itself, space became more limited due to distancing requirements, and staff workload became more challenging as they had to don and doff personal protective equipment between each patient. Sunnybrook was one of the 14 emergencies in Ontario to implement virtual care, which occurred in the fall of 2020. Initially, it was offered or staffed by emergency physicians for less hours than is offered now. There were very positive outcomes seen in the early days of virtual care, such as tremendous patient satisfaction, deferred emergency visits, and providing timely access to care. In the fall of 2023, Ontario Health decided to expand the hours and have nurse practitioners provide the virtual care. So since the fall of 2023, NPs have been the care providers in the Sunnybrook Virtual Emergency. Currently, we work 7 days per week with coverage between 1 p.m. to 9 p.m. We have the capacity to see 19 patients per day. There's an on-call emergency physician that we can consult with. And there's also currently 6 virtual emergencies in Ontario with the hopes of expansion. Next slide. Although older adults only account for 25% of emergency visits in Ontario, they are a vulnerable population whose needs have to be addressed. Older adults are vulnerable in the emergency as they often have mobility issues or chronic pain, which makes waiting in the emergency uncomfortable. Long wait times are associated with sensory overload and sleep deprivation. The chaotic and busy environment is less than ideal for interacting with nurses and physicians. If admitted, there are often long wait times in the emergency, which leads to outcomes such as delirium, which leads to an increased risk of falls, often leading to injury. Also, there are hospital-acquired pressure ulcers. Interestingly, I spent 4 years working as a nurse practitioner on an inpatient orthopedic unit where I cared for hip fracture patients. I consistently saw the effects of prolonged emergency and hospital stays on the older patients. At best, the delirium was short-lived, but sometimes it led to permanent worsening of pre-existing cognitive impairment. Although we provide timely and convenient access to healthcare, there are challenges specific to the older adult in the virtual emergency setting. First, there's access related to the proverbial digital divide. Older adults may not have access to computers or smartphones. And even if they have access, they may have difficulty using video conferencing platforms. Oftentimes, we will have family members supporting the older adult, and then sometimes we do have to go to a telephone call, which leaves out the ability to physically assess the patient. Another challenge is we only have 20-minute appointments. 10 minutes is spent talking to the patient. In that 10 minutes, we have to ask many questions about signs and symptoms related to what brought them to the virtual emergency, sort out what medications they are taking and what medical conditions they have. It is a lot and can be overwhelming for sure. This is further complicated if there's any degree of cognitive or sensory impairment. Occasionally, even if we do direct patients to the emergency, they do not want to go due to the wait times and the discomfort of waiting. For these reasons, Sunnybrook is researching how to better meet the needs of older adults in the virtual emergency.
I will continue from here. So the objectives of our current study is to better understand how the virtual ED can meet the health needs of older adults and to develop strategies to raise awareness and uptake of the service. To achieve this goal, our team is undertaking a retrospective chart review of the virtual ED utilization by older adults and also qualitative interviews with older adult patients, their family members, caregivers, and clinical staff to learn how older adults are accessing the virtual ED and about their care experiences. So today we will share some preliminary findings from this work. Our chart review is still very much ongoing, but I would like to share with you some characteristics of the older adult population that has been using Sunnybrook's virtual ED. About 12.5 virtual ED users were older adults. Since in comparison, older adults account for 25% of patients visiting in-person EDs in Ontario and approximately 38% of in-person ED patients at Sunnybrook. Older adults seems to be underusing the virtual ED service. From December 2020 to January 2025, which is about 5 years, the Sunnybrook virtual ED saw close to 1,500 older adult patients, with the oldest patient being 102 years old. The average age of older adults virtual ED users is 76, and the majority of them are female. Interestingly, almost 91% of older adults who use the service had a family doctor. with female patients being significantly more likely to have one. This may be an indicator for mobility and transportation challenges, as well as availability of appointments with MD. The majority of older adult patients, close to 80%, live within the municipality of Toronto, and with additional about 13% a bit farther in the York region. However, you may see that small percentages of patients from other places in Ontario use the service, with several even being out of province. For the majority of older adults patients, Sunnybrook isn't the nearest in-person ED, as this was the case for less than a third of patients. The chief complaints vary, with the most common being respiratory, such as cough and nasal congestion, and issues like upper and lower extremity pain and injuries that are often related to falls. While respiratory complaints are very common in EDs in general, in all age groups, fall-related injuries are more common in the older population. Mary, from here.
So just to provide some context to this slide, there are 6 potential outcomes from a virtual emergency appointment. At minimum, we provide health teaching on how to manage their health condition and what symptoms would necessitate follow-up. The second outcome is we order blood work or other labs or imaging such as x-rays and ultrasounds. The patient is always advised to follow up with the virtual emergency to review results, which then speaks to the referrals virtual ED follow-up of 8.2% and also the virtual ED revisits of 7.5 and 9.9%. A third outcome is a prescription is provided. A fourth outcome is a patient is directed to go for an in-person assessment with either their family doctor or a walk-in clinic. An example might be ear pain or a sore throat. A fifth outcome is a referral to a specialist. And as you may have figured, often there are mixed outcomes. For example, a prescription is given, a test is ordered, and there's referral to a specialist. Finally, the sixth outcome is we direct the patient to go to the emergency. When we do this, it is an expectation that we discuss the case with the on-call emergency physician, which would partially explain the 23.6 ED-MD consult rate. Our clinic's data shows we direct 9% of the virtual emergency patients to go to the emergency for an in-person assessment. So this would mostly explain the 11.6% in-person ED revisit of 11 within 24 hours.
So additionally to our chart review, we also conducted 4 older adults patient interviews and 3 healthcare providers interviews. For now, it seems that the patients are finding the virtual ED to be a valuable and helpful alternative, and the service to be efficient in saving them the waiting time in an in-person ED, freeing up space for others with more serious conditions while still receiving the care that they need. A patient shared in an interview that they're finding the virtual ED to be like a partner, something they can rely on when they are unsure what kind of care they need or what they should be doing regarding their health. Patients also spoke about areas in improvement. They suggested having staff that specializes in older adult population and less wordy text in the interface. Staff members mentioned time constraint as a significant limitation, as the virtual ED appointments are about 20 minutes. This can make the appointments overwhelming for all adults, as Mary described. And one suggestion is to improve this is making the appointments a bit longer and perhaps earlier in the day when older adults are usually more available compared to other age groups. I will just quickly summarize. As I mentioned before, our evaluation is still in its very early stages, but the virtual ED seems to be promising options for older adults. There are some potential barriers that should be addressed, such as lower digital literacy and making the interface more accessible to individuals with cognitive or sensory impairments. We're examining how this virtual urgent care option meet the physical, emotional, and social care needs of older adults in order to develop strategies that will increase their access to compassionate virtual care. We are exploring the perspective and experiences of older adults, their caregivers, and healthcare professionals with the virtual ED, with the end goal to co-design approaches to help older adults and providers to better use the service, the virtual ED. Thank you very much.
Thank you, Marina and Mary, for presenting on this important and growing area around the virtual emergency department care. There's a question in the Q&A section that says, have patients commented on if going to virtual ED is faster, better, easier for them versus going to their family doctor, given that over 90% have a family doctor? And that's from Vicky.
We're still doing the qualitative interviews, so I haven't heard that comment from patients yet, but the study is still ongoing.
Great, thank you. So stay tuned, Vicky, for more to come.
Yeah, we'll be happy to share results once the study is completed.
Great, and we also have Bruno, who says, how can it even be feasible to address delirium by virtual approach with the older adults or the natural caregivers? So maybe if there were challenges in addressing that type of condition?
I think from the history, so usually if there's someone is in delirium, they're not able to actually interact with us, but their family members would, and they would be able to explain that they're not at baseline. They're, more confused, more say, not sleeping as well, not eating and drinking as well. So delirium can be identified. We can't address it per se, but we can then tell them where to go next for care.
Great. Thank you, Mary and Marina. There are a couple of other questions, but for time purposes, I will save them for the general Q&A, or as well, feel free to answer them in the chat. Okay, so thank you.
Thank you.
So we'll now move on to our final presentation, switching gears from research to moving the dial. So I invite Justin Wies as our third presenter. And as an introduction, Justin will be speaking on NovaSense. NovaSense Technology Limited is advancing the intelligent sensing solutions to support aging populations and individuals at risk of pressure injuries. Its flagship product, the Smart Sheet, is a soft, flexible, and stretchable AI-driven sensor system that continuously monitors pressure and shear forces, providing real-time feedback for proactive prevention. By integrating advanced materials and data-driven analytics, NovaSense aims to enhance independent living and long-term health outcomes. Justin Wies, founder and CEO, leads the company's research, development, and commercialization efforts, leveraging his expertise in electrical and biomedical engineering to bridge cutting-edge technology with real-world healthcare challenges in aging and mobility. So I invite Justin to share the screen, and over to you.
Hi, can you hear me?
Yes, we can.
Are you able to see my screen as well?
Yes, it's clear. Thank you.
Okay, awesome. Thank you so much for the introduction. I actually forgot about that introduction, so that kind of throws my presentation a bit away. But so my name is Justin Wies. Thank you so much for having me today. And as mentioned, I'm the founder and CEO of NovaSense Technology, but also a PhD candidate in biomedical engineering at the University of British Columbia. And today I have the pleasure to give a bit of an intro of what we do at NovaSense and also our technology, give a bit of a glimpse into that. But before I start and continue to my next slide, I would like for you all to be aware of your current situation. So I can assume with some confidence that the majority of us, we are either sitting or lying down watching me present today. And for the most of us, we have the feel and sensation to know when a position is getting uncomfortable. So when you're sitting or lying down, you feel the discomfort because you have the sensation. And so what do we do after that? We readjust ourselves. And we actually do that subconsciously when we're asleep as well. But imagine you don't have that sensation or the mobility. What now? So millions of people around the world are exactly in this situation, and they're susceptible to a complex chronic wound known as pressure injuries. A wound that is developed or formed due to prolonged pressure and shear forces. And it's actually considered to be one of the most complex, costly, most physically debilitating medical conditions, and it is preventable. So I would like to emphasize on the preventability here. And when we just look at the impact that it has just in North America, there are over 3 million cases each year with 60,000 people, more than 60,000 people fatally dying from it. And the cost associated with it, healthcare cost, is over 27 billion each year. And there's no current gold standard in treating or preventing pressure injuries. And this is where we come in with NovaSense. We are trying to create a technology that, one, can be personalized to the user directly, but also continuously measure pressure and shear to give them education and comfort as well, and alerting healthcare professionals and the users directly before pressure injury develops. So how do we do this? So we have the SmartSheet technology. We designed a soft, flexible, and stretchable pressure and shear sensing technology that can be placed on any kind of surfaces, like, for example, wheelchair support cushions or their mattresses. We continuously monitor them, and then with our currently under development, our AI system that can basically look at all the different intrinsic factors, considering them, we can create a personalized user solution directly to inform the users directly, as well as the healthcare professionals before the pressure develops, due to the studies that we have been conducting at the University of British Columbia as well. So just to go over the sensing technology, that the evolution of the SmartSheet and the soft sense technology at the University of British Columbia, we have in the molecular mechatronics lab, we have been developing soft sensors, transparent sensors, sensors that are able to detect proximity as well as multi-touch, and moving on to be able to be bent, stretched when somebody will be sitting down, for example. So in the top video, you can see when we bend the sensor that it shows the performance of touch and when a pressure will be applied directly. And on the bottom, we could see, for example, when there's incontinence. So a person is sitting or lying down and there's some incontinence. Will it affect the sensorability? We're able to actually detect moisture detection directly on the sheet, but also it won't affect the performance. So once we clean it, it will still work as it initially should. But as I mentioned, that we require stretchability, and we require something that is soft and flexible, that can fully shape conform to the users directly, able to measure accurately pressure and shear when they're sitting or lying down. So we need to create a sensor that, one, doesn't lose its performance characteristics when it's being stretched, but also providing a way of pressure relieving support that can alleviate the pressure distribution on the back, on the heels, or when they're sitting down directly on their IT bones. And now when we also directly mentioned before that pressure and shear is a combination that affects the formation of pressure injuries, we needed to create a sensing system that, one, is able to measure pressure accurately over long periods of time, but also have the capabilities to measure shear. So here we're demonstrating the softness of the sensor with a strawberry, but also showing that we're able to measure normal pressure forces, but also directional shear. So let's take it back again to the SmartSheet. So as I mentioned, we have the sensing technology, but we're also currently developing an AI system that can understand the sensing data that we're getting, but also the users themselves. So why am I bringing this up is because pressure injuries is a very complex chronic wound, which has over 200 risk factors associated with it. So age being one of them, sex, people living with spinal cord injury, other health criteria such as cardiovascular diseases or being diabetic, and their lifestyles. So basically what happens is when we're sitting down or lying down, we're occluding the blood flow, the delivery of nutrients and oxygen to the tissue. And if we don't reposition the person, ischemia would happen, or necrosis, so tissue death would occur. So we need to understand when that would happen for a specific individual. So in our studies of developing the pressure injury prevention system, we're actually looking at, one, the physiology, looking at the tissue oxygenation of how this pressure injury affected, and also looking at the different intrinsic factors such as age and sex, and see how we can create a prevention system that can go hand in hand with the SmartSheet, creating a personalized user solution that can be used for community as well as clinical settings. So how this would work is you could implement the smart sheet or integrate it in any kind of surface that you would be sitting or lying down. And you would enter or create an account with your user profile. So understanding like if it's a male or a female and their sex and other health criteria, we will be able to create the basis, the foundation of that pressure time curve for you specifically. And later on, we're continuously monitoring, we're collecting more data and understanding your movement patterns, recognizing different distribution, and creating and understanding the situation and providing smart notifications, may it be directly to the users who will be able to readjust, or to the healthcare professionals, alerting them to readjust a patient, for example, before a pressure injury would develop. And as Mary mentioned before, in the ER, pressure injuries do develop. And this is just an example. We are actually working with our clinical advisory team to fine-tune this, how this could be implemented. But as I mentioned before, we're trying to create something that can be implemented in clinical settings, such as in hospitals, but also for at-home use or long-term care facilities, where we could integrate the smart sheet into the hospital beds or stretchers and basically alert healthcare professionals or the users directly, or integrate directly with a dynamic cushion or mattress, creating a fully autonomous system. Looking at our competitive advantage to other pressure mapping systems is that we're fully shape conformable. This is something that we have been co-creating with people living with spinal cord injury and the elderly population to figure out what would be best fit for them. And we're still in the process of creating that best fit solution. But shape conformability is important for accuracy, but as well as we want to understand the different complexities of a person when they're sitting or lying down, able to measure pressure and shear, as well as creating a prevention system that actually provides smart notifications and alert before stage 1 pressure injuries develop. A bit of an overview of different pressure mapping systems, which are capacitive and resistive. Where we distinguish ourselves is that we have pressure and shear capability, as well as fully shaped conformability for accuracy, as well as comfort to the user. The pressure support part is regarding that we can scale up our sensor in size and resolution, but also create that softness that alleviates pressure when they're sitting directly on, similar to a support device. We're targeting the clinical and home market, so not just the clinical sector, but actually want to create a device that people can take home with them for continuous monitoring, education, and ease of mind, as well as creating a prevention system that provides that smart notifications to the users. And our core team of Novasense consists of myself, who has over 8 years of experience in soft sensor, smart materials, and pressure injury research, as well as my supervisor, Dr. John Madden, who acts as a scientific advisor, who is a globally recognized expert in smart materials and flexible electronics and sensors, as well as Dr. Onindo Roy, who acts as the R&D engineering lead for the materials part, where we're implementing advanced materials to advance our fabrication process of the smart sheet, so moving into a rapid prototyping realm. And I would like to thank AgeWell for giving me the support of creating a support network for me and Novasense to go to a next stage of commercialization, hopefully creating a solution that can really impact the aging population, and be part of this network to hopefully get deeper into it, to co-create together with the aging population and really create a solution that really fully can impact the aging community. And I also would like to thank my other funders and supporters across this research endeavor, and hopefully we can commercialize something that can truly help prevent pressure injuries in the future. Thank you.
Thank you, Justin. Thank you for sharing Novasense with us, truly moving the dial in that conversation and in that digital solution space. So I will invite all of our presenters to come back, and you can turn on your cameras for general Q&A. And we'll also have questions to the entire group or to specific members. So feel free to either put your questions in the Q&A session for a specific presenter or to the overall group. We'll start with the question that was to Justin. Elizabeth asks, is the smart sheet an option to replace the low air loss mattress?
It's not to replace the support cushion or mattress themselves. What we're providing is the sensing capability. So support devices usually help alleviate pressure, not necessarily shear, but alleviate pressure and distribute the pressure. We can do that to some scale. But what we actually provide is, for example, for an air cushion or mattress, if it punctures, our smart shear will be able to detect that because we would see that on the pressure heat map. So what we do provide is, in a way, you can imagine it being in a secondary skin, that we see that, and with the AI system, we create that neural system that can send the signal directly, let's say, to an actuating cushion, which could act as the muscle, and help the user or healthcare professionals to alleviate the pressure and redistribute the patient.
Great, thank you, Justin. And I'll circle around the table. So there was a question for Mary and Marina from John asking, what consideration have you given to any potential technology limitations for older adults?
Thank you for the question. There was a lot of work done to make the interface as user-friendly as possible. Mary also mentioned the option to have a phone call and not a virtual meeting over Zoom. It doesn't really makes all the problems go away, but that's some of the solutions. Other possible solutions can be increasing the availability of digital literacy programs that can be even given by the hospital, provided by the hospitals. And of course, on policy levels, such as making computers more available in community centers and other areas and services that older adults are using.
Great, thank you. Go ahead, Mary, if you would
Oh, I
like
was just
to
going
add.
to say, I think it will become more clear as we do more interviews and just see what sort of solutions might come up from there. But it's definitely needs a lot of brainstorming for sure.
Thank you, Mary, as well. I will circle to James because there was a question earlier for James. For your technology, could this be commercialized with healthcare partners and used in care settings everywhere? So in other words, how would you scale up?
That's a very good question. This particular area of research, where we're using computer simulation to, model care provider workload, it's a very novel area. We're one of the actually we're the only team that's actually looking at complex care, particularly in terms of simulating workload and care quality. So in terms of the outlook to commercialization, I don't think we're at that stage yet. I think we still have ways to go to just understand, how we can use this type of technology, and then before getting to the commercialization stage, looking at what might be some challenges to, adoption, and also understanding, who would actually use this kind of technology in a sort of daily operations scenario. So we do actually have a semi-structured interview study that we're planning to carry out this summer, where we will actually be speaking with a variety of individuals throughout the healthcare ecosystem to try and answer some of those questions. So that's where we're at yet. I don't think we're ready for commercialization as of yet. Thank you.
Thanks, James. Lots to come. These have been excellent questions, and I'm being mindful of time. So if the presenters are okay, if there are questions that others want to then reach out to you after this session, if they can reach out to you through email, that would be wonderful. I will actually ask one more question to the entire group, and I think it'll be a good way to close off this exciting session. And the question is maybe capturing in 1 or 2 words, what are your hopes for age tech, and specifically for the future of age tech? So if you're able to capture that essence in one powerful word or a few words, that would be wonderful. So who would like to start?
I will. I think it has great possibilities. So I would say there's a lot of promise for the future.
Cool. Promise for the future. I love that, Mary. Anyone else? Maybe I can go to James.
Yeah, definitely there's a lot of possibilities. in particular for our work. We just believe that technology should factor in the care providers as well as the recipients of care.
Great, yes. So factoring in care providers and yeah, having that co-design process. Wonderful. How about Marina?
Just following up on what James said, I think collaboration between patients and caregivers and healthcare providers will be very positive as a future development.
Wonderful collaboration. And then Justin, you have the final
Yeah.
word for us.
I mean, I'm basically echoing everybody, but I think especially like what AgeWell is doing, bringing a network together with different clinicians and like entrepreneurs and researchers, that's what we need. Able to co-create, co-design, and that's exactly what we're trying to do with the Smart Sheet and with NovaSense. We need to hear the inputs of everybody because we, as a researcher or as an entrepreneur, we only know that much of a small spectrum. We need to understand a lot more. And that's really how everything can progress, not just in the aging community, but in anything that we want to do. So it's really great that we have this opportunity with HWell to have this network. And I really encourage that co-creation because that's what makes the future bright regarding technology implementation.
Thank you all. So collaboration, co-design, wonderful, a network. So thank you very much, everyone, for an exciting session. It's been a pleasure with you all. And I look forward to continuing these conversations. As I mentioned, do not hesitate to reach out. But thank you again for joining this exciting EPIC session. Have a great day, everyone.